Welcome, everybody. My name is Sue Grinnell, and I'm with the Public Health Institute. And I'm excited today to hear from the Imperial County CACHI Catalyst site. They are going to share with us their story in a case study format. And you're going to be hearing from 4 of the staff there, and they will be introducing themselves. So with that, I'm going to turn it over to Christina Olson.
Well, thank you guys so much for allowing us to be here today. We are very excited to present our CACHI backbone story. We thought you guys could appreciate the humor in that title a little bit. We're all from Imperial County, and we are all part of the Public Health Department, which really serves as a backbone for the larger collective efforts that are happening here in our community. So to provide an introduction, I'm going to turn it over first to my colleague, Denise.
Hello, my name is Denise Andrade. I am the Health Promotion Manager with the Imperial County Public Health Department, serving as the CACHI Program Manager. For the purpose of context, the Public Health Department is the agency that applied for the CACHI funding on behalf of the local health authority.
Hi, my name is Dio Gamboa. I am a Health Program Coordinator for the local health authority, and I work closely with our partnership and our steering council.
Hi everyone, my name is Belen Mendoza and I'm the Special Projects Coordinator, and I work with the Measures, Metrics, Integrated Sustainable Communication and Technology into our efforts.
And my name is Christina Olson. I am the Local Health Authority Commission Manager. As we've kind of talked about things, just to give you a little bit of context, that Local Health Authority Commission for our community is somewhat of that governance body or the leadership. And I would be remiss if I didn't also say that a part of this team, this is the core backbone team. We also have our director of the Public Health Department, Robin Hodgkin. She has really pioneered and pushed these efforts forward and was one of kind of the visionaries that started all this work. So we're excited to present to you today on some of the things that have developed over the last several years. So before we really begin, we wanted to provide everybody a context of where we are in Imperial County. A lot of you know or don't know that we are actually in that map on the red spot here. So we're in the most southeast corner of California. We border Mexico and we also border Arizona, but we have 2 borders with California counties as well. We're a very large geographic area spanning over 4,000 square miles. And within that area, we actually have a smaller population, so just over 180,000 residents. What you'll see there is that we have a very interesting geography in our community. We're a very desertous region. We have some areas below sea level. We have sand dunes, but we also have some mountainous region as well. But one of the surprising things that people note when they're here visiting Imperial County is that we're actually an agricultural region as well. Thanks to the Colorado River that runs through our community, we actually grow tons of vegetables, especially in the winter when our weather is great and everybody else is covered in snow around the United States. So with our smaller population, they're centrally focused kind of in that center area of the county. We have 3 or 4 larger communities that people tend to congregate in, but we also have a lot of smaller residential areas that are more dispersed, some of them unincorporated, and that obviously presents its own challenges as we're talking about healthcare and delivery of services to different regions.
To give you all some more context on Imperial County, we pulled up some demographics that might help paint a picture of our community. So in terms of our racial makeup, we have over 80% of our population being Hispanic or Latino. In terms of our median household income, we have over $43,000 annually, and that's pretty low compared to that of California, which is at $67,700. In addition, our unemployment rate is over 20%, which is the highest in California, and I believe one of the highest in the nation. And compared to California, again, that's at 4.4 throughout California. Some examples of our need here in Imperial County in terms of our physician shortages for primary care providers, our mental health and dentistry, we have on the slides comparison between Imperial County in terms of population per physician, much higher than that of California.
So So when you hear Imperial County, you normally think of all the demographics that Diego just spoke about, which often do overshadow the good that exists in our community, giving people this interesting idea of what our community is truly made of. The truth of the matter is that although we do have a lot of need, the people that live here are proud to live here. Despite the challenges of the community, we are a tight-knit community and take pride of what we have to offer that is not commonly really known about us. For example, as you can see in the slide, did you know the Blue Angels winter training occurs in our county? It's things like these and like the Carrot Festival, CACHI, and many other festivals that make us proud. Aside from these activities, something that makes us so unique and powerful, given that we're a border town, is our Hispanic culture. As Diego pointed out, we have over 80% of our population identifying as Hispanic Latino. We might be a small community, but we also take pride in many other things that we're part of, such as our agriculture. Like Christina mentioned, our community grows a lot of the veggies that make it to your table, and we're very proud of that. Again, it's important for me to reiterate that regardless of statistics, we are a community that cherishes our heritage and our family values. We are full of many opportunities, and when a need is found, we don't hesitate to come together for the sake of improving the way we do things. Because regardless of our views, we all cherish and agree that our community is a great place to live. I mean, that is part of the reason why I decided to return to Imperial County. We don't let that define us. Instead, we opt to look at the good that makes us who we are. So next time you see a Blue Angels show or eating a salad, stop and think of Imperial County.
So now that you guys have a bit of an introduction about Imperial County, we'd like to walk you through some of what has occurred over the last several years to make our collective efforts happen. We actually applied for CACHI much later after this collective effort began. So we often refer to this work that we use the CACHI rubric with as collective efforts. And those really began in 2013. If you all recall, in 2012, the Affordable Care Act was passed, and California as a state started to move from fee-for-service to managed care for the Medi-Cal program. Imperial County at that point was a bit resistant, given our unique geography, the high shortage of care providers in our community, especially specialty providers, just very unique circumstances that we have here. There was a lot of hesitation about taking on managed care. So for about a year, we resisted, and then in 2013, we were actually mandated by the state of California to make the transition to managed care in our community. When that actually occurred, our community leaders and residents got together and said, how do we do this differently? So we had a group of health leaders that went to the Board of Supervisors and advocated to work with the state on creating our own model of managed care. We were very grateful to be allowed the opportunity to do that, and that actually established the Imperial model of managed care. We are very proud that we're the only community in all of California that has the Imperial model, and under this model, the way it works is the county actually is allowed to choose to work very specifically with one local Medi-Cal managed care plan. We ended up using an RFP process to select that Medi-Cal managed care plan, which right now is California Health and Wellness, which is part of the Centene Corporation. And then we also have, as a part of this local managed plan, as a part of this Imperial model, we have a second plan that's selected by the Department of Healthcare Services. So it's essentially somewhat of like a two-plan model in our community where we work very specifically hand in hand with the plan that we have selected. Under this whole model, it allowed for us to establish a local health authority. The local health authority in our community is a collaboration of 13 leaders from various sectors within the community that work on a monthly basis together with the health plan to decide how we can improve our system of care, really focusing on prevention, the social determinants of health, and talking about sustainable change in our community. That local health authority includes individuals such as the CEOs of our hospitals, the CEO of our federally qualified health center, the chief medical officer from that establishment as well. We also have representation from county agencies such as Behavioral Health Services, Social Services, the CEO's office. We have one of our Board of Supervisor representatives, but we realize that this group has to be diverse as well and needs to include additional perspectives. So we also have a Joint Chambers of Commerce representative and a seat for a Medi-Cal beneficiary. There are several others, but 13 in total. And this group meets on a monthly basis, as I mentioned before, to really work on our health system. But what really makes this model incredibly unique was the establishment of a wellness fund in our community. When we worked to select a local initiative healthcare plan, which as I mentioned is California Health and Wellness, we worked on them with establishing a wellness fund. And that's actually a contracted agreement where we have our local initiative plan paying a portion of their per member per month fees into a fund that then the local health authority commission has decision-making power over. In addition to the PMPM, we also have a portion of shareable revenue that gets deposited into that fund on an annual basis. As you can see in the pie chart there on the left, what we've done over the last couple years is really develop a financial strategy for how we can invest those monies. We really feel strongly that we need to focus on systems changes and meeting needs that otherwise wouldn't be addressed. We're a community of high need, and really, truly, funds could be spent really easily on a lot of different things. So we've been very thoughtful in the process of how we distribute and create different buckets that will allow us to meet different opportunities. So we have things like capacity building, and we'll talk a little bit more about initiatives that have been funded under that. We also have one-time high need, knowing that there will be things that happen that we just need to get to. This also supports administratively some of our staff for the local health authority, which is the backbone, but it doesn't support the whole because we have a lot of blending and braiding within our community. So in 2015, the Commission had gotten to a point of creating their first strategic plan to help guide some of what they'd like to do. At that same time, our community had actually come together to actually create a community health improvement plan. This was the first time we had ever done a comprehensive community health assessment, and it allowed for us to really see some great new input from not just stakeholders that are always at the table, but new partners as a part of this process. With that community health improvement plan being developed, the Commission said this is a great opportunity for us to align and really see what priorities are out there. So the Commission then adopted that community health improvement plan. And at that same time, in 2016, a lot of things were happening all at the same time. In 2016, what happened is we had the California Accountable Communities for Health Initiative released. We were incredibly surprised and excited to see that there was something out there that really was a name for a lot of the work that we were doing. So we as a community were enthusiastic to apply for that and very grateful to be awarded one of those first sites that was able to receive the funding for CACHI. Now that funding and the additional technical support has definitely been very pivotal in helping to form our infrastructure. But as I mentioned before, we have stuck kind of with our name of collective efforts since our processes all began before we ended up becoming a CACHI site.
So I know these concepts are not new to all of you, as they are ACH concepts. However, it's important to mention that although these concepts were officially brought to our community through CACHI, these are concepts that we had already been working with when developing some of the work that had been initiated prior to receiving the funding, as Christina just spoke about. In Imperial County, these concepts have served as that general uniting forces that are utilized by our ACH. Through implementation of the CACHI funding, we have utilized these concepts to better align the work being done by the different stakeholders in our community, such as what was done with the two major projects that we will be diving into during this presentation, which are the Asthma Community Linkages project and the Health Leadership and Communications training. In essence, this image demonstrates what the ideal model of our community would look like. Now, this doesn't mean that this is what has been fully established, but it is what is being utilized as the model we want to follow when making decisions. This is where we want to be when talking about decision-making processes in Imperial counties, when talking about the collective work happening here. Currently, we have activated, to some extent, the 4 groups on the right side of this image, which include the local health authority, the community health improvement partnership, the steering council, and the backbone being us. Although not all details have been finalized, all 4 groups come together to make decisions for the purpose of supporting this greater effort. The local health authority serves as the governance leadership to the collective effort. It's the steering council that coordinates directly with the partnership and with the local health authority, the public health serving as backbone to all of these efforts and being involved in all conversations. Additionally, it's important to mention that in addition to the four described groups, the local health authority is also inclusive of 5 other committees, including provider, quality improvement, finance, executive, and policy. It's through this joint decision-making process that the Wellness Fund has been utilized to put forward funding that supports the work of this larger effort. For example, putting an RFP for our Asthma Community Linkages project and investing funds in building capacity in our community through the health leadership and communications training, which we will further elaborate on. These are only 2 of the different efforts that are being funded with our Wellness Fund. What's important to understand that is that although CACHI requires for a Wellness Fund to be established, our Wellness Fund was established prior to receiving CACHI funding. And it's not only focused on funding asthma interventions as shown in our portfolio of interventions. The goal as seen in this graphic is to fund different initiatives, which is what essentially is being worked on as part of our investment strategy and our financial strategy. Similarly, the goal is to get funding from other areas aside from our local health plan as we see the value of blending and braiding of funds. So like I mentioned, the Wellness Fund has begun funding initiatives, Asthma Community Linkages being the first. This initiative was worked on for the purpose of transforming the clinical system and that clinical community linkage through the focus of asthma efforts in our community. They have invested $1.5 million, allocating it beginning 2017 and ending in 2020. Although the dates of this initiative show a start of 2017, and it looks clear and to the point, it's important to emphasize that we actually had to put the RFP out earlier, but decided to pull it out to align with CACHI framework. It was a lot more work than what we had anticipated, as you can see with this timeline. So although our first initiative was released with a 3-year funding period beginning in 2017, that timeline of how this funding initiative started was in 2015. Just for the purpose of providing more context to demonstrate the complexity of this process, it's extremely important to share that it was in 2015 when the LHA released, but later retracted. When initially released, this RFP was actually aligned with Healthy People 2020. It was in 2016, while trying to decide when to release again, that CACHI funding came around, really giving our stakeholders an opportunity to realign the initial RFP with the framework provided by CACHI. As you can imagine, it was through a lot of brainstorming between the steering council, the local health authority, and the backbone, and that partnership to determine if the new vision made sense before re-releasing in September 2016. Although applications were received, a review committee determined that they were not qualified applications to carry on the work outlined in this RFP. With feedback from this committee, the LHA decided that reality was that the applications were as good as they were going to get, and rather than spending time and re-releasing this RFP, it was important to fund something differently that we called the capacity building phase for the applicants. The award notifications were actually very different to what we're used to receiving when we receive funds. The notice was titled Intent to Award Upon Completion of this phase, which was funded truly with the intention to give these organizations, one of them being a community-based organization, the skills needed to put together a program that included this CACHI framework. This was an intense phase, like I mentioned, that both backbone and grantees engaged in for the purpose of development of what Diego and Belen will elaborate, essentially working on the development of phase 2 and items necessary for phase 3. Although the live date is shown as September 2017, full systems implementation didn't actually happen until December 2017. All of this is important to clearly outline how extensive this process was. The reality was that the timeline we had originally hoped for was not as simple as we had anticipated, and as you can see in this timeline, it's pretty obvious how time extensive it was. For the backbone, though, it was extremely important for us to be flexible and provide all the necessary support to help move this timeline forward.
So as Denise mentioned, phase 1 was a phase that was not planned, but it was funded. We understood the limitations of the organizations at the table, and upon completing the capacity building phase, the organizations at the table received a $10,000 stipend for the main funded agency and $5,000 for their subcontractors. I want to reiterate that this was not a phase that had initially be planned for. And we found that as a backbone, we had to continue to support our stakeholders wherever they may be in their journey to understanding and incorporating ACH principles. This was a hard process that required a lot of time that was not accounted for, but it was necessary. Our community had a limited number of organizations, so those that had the willingness to participate, we had to give them the tools to be successful. We went through all stages of group development. There was forming, storming, norming, and finally performing. It was not a smooth sailing, but during this process, we were able to get a view into their organizational needs. It gave our partners a sense of ownership and created a bonding opportunity that strengthened new relationships that ultimately translated to trust. I want to share that it's okay to change gears and adapt to the needs of others to ultimately support our goals of the ACH. We accomplished a lot during this phase. We were able to create the implementation, alignment, and metrics plan that essentially became the guiding document for the Asthma Community Linkages project, where we aligned measures and metrics to evidence-based models and tools, as well as adopted a standardized asthma model across participating organizations. And because of how small our community is, we were able to include 100% of those organizations providing asthma home visiting services. So after we had created this guiding document in phase 1, we had to put it into action. So in phase 2 is actually when the contract started. Although they had a capacity building phase, phase 2 was a granted time period to help the organizations implement the changes they needed in order to move the work forward, outlining the implementation, alignment, and metrics plan. During this time period, there was training, hiring of new personnel, modification of their electronic health record system, and identification of those physician champions to help with the cultural change needed to implement the changes. This is essentially when the rubber hit the road and we went from theory to practice. It was interesting to see how this phase allowed the participants to understand their own organizations better. Essentially, the participants were faced with working outside their lanes and regular duties and responsibilities to be able to bring the different gears together and move the work forward. This further built the capacity within their own organizations. And due to the relationship and trust that was established during phase 1, the backbone was very active during this phase. As the backbone, we were open to help and provide technical assistance whenever needed. Some of the major gaps that the backbone had to fill were in the electronic health record system, or EHR for short. Because the EHR had mobility issues and the EHR would not be able to be completely built out by the established go-live date, we found out-of-the-box ways to help collect structured data. SurveyMonkey, a software designed for surveys, was used to help collect health records as a stopgap until the hospital built out their EHR. SurveyMonkey was phased out after the partners built out their system, but it provided that much-needed band-aid to move the work forward. The backbone also helped establish other means of communication to help share materials and have a means to share challenges and lessons learned across participants. Organizations that usually don't work collectively latch onto SharePoint, a secure internet to share materials. Essentially, it was a close to the public website where funded organizations could share resources and lessons learned. In our community, this was a big deal. 2 competing organizations were working collectively. That meant sharing information, lessons learned, resources, community programs, and so much more. There was additional support that the backbone provided, but it was an interesting time for a backbone. This was the first time where we were integrating into our partners' organizations and aligning their goals and objectives to those of the ACH. For us, it was like walking on eggshells. How much can we integrate and infiltrate without breaking the trust that had been built in phase 1?
In phase 3, the Asthma Community Linkages project went live, how Denise mentioned earlier. However, when we initially thought of the go live date, we thought it would be smooth sailing. However, like many projects that are related to systems change and creating new pathways, we realized that in the first 3 months, it was much more like a pilot project in which we had to do much more planning for implementation, restructuring, and learning as we went when we were putting theory into practice. We encountered a lot of roadblocks and challenges, and as Belen mentioned, there was things like the SurveyMonkey and SharePoint that were created to help alleviate those issues as much as possible. But this is also where the backbone allowed our partners to really engage and take ownership of this project and allow them to work with their organizations to see how best to implement this project in a sustainable way. So full systems implementation didn't actually happen until 3 months after the go live date, which is in December of 2017. In the full systems implementation phase in which we currently are, there's a lot of auditing that's going on. There's also a lot of quality improvement efforts that are happening through our organizations. For example, one of our partners is working with their quality improvement committees to inform them about the progress and how to address changes or challenges that are happening in their clinic system. They also have been focusing a lot on sustainability and how do they make sure that this program is sustainable past our grant funding period. And things as simple as including medical information or health insurance information to their providers so that they can ensure that their patients can get their medication covered. Also ensuring that instead of focusing a workflow that's heavily reliant on a provider or physician provider, to include nurse practitioners into the care team to allow for sustainability and ease of access to patients. Throughout this process, we've learned a lot about what it takes to do systems changes, which, as you all can see, is really a long-term process and takes a lot of multi-level changes, not only at the provider level, but also at the executive level. We also learned as a backbone that our responsibility to support this changes depending on the need of our partners, and having to communicate extensively with them to see where can we be of assistance. There was times that we had to take steps back and say they have it figured out, they can move forward those systems changes. And there was times in which they requested our help and we were much more involved in that process. But overall, it was very important that our local health authority who funded this project to understand the timeline and the actual reality of this process of system changes. So as a backbone, it was our responsibility, and it still is our responsibility, to talk to them and explain what improvements have been made, what are the challenges, and really understanding what system changes looks like and where their monies are going. To sum up for asthma community linkages, as we mentioned, our first phase was a completely unplanned investment, but it was something necessary to make sure that we were all on the same page. We can develop something that made sense to our systemic changes that we were looking to make to improve asthma management in Imperial County. That required a 6-week long process, but it was necessary for us to fund it. For phase 2 and 3, those were grant funded, but as we mentioned, phase 2 was a designated time to allow them to start these system changes that weren't going to happen overnight, and we knew that they needed some time and TA from the backbone to help make those happen. And currently phase 3, which is implementation, where we are still continually communicating to make sure that whatever assistance they may need from us, that we can provide that. This leads us to our second, the local health authority's second funding initiative. So as we mentioned earlier, the Wellness Fund isn't specifically only for asthma. It funds other needs here in our community, whether that's through our community health improvement plan or through our strategic plan. But something that was brought to the local health authority's attention is through the community health improvement plan, we had a community health assessment in which we got survey information from our community stating what they felt was a need in our community, but also how could they be involved. And many of the feedback that we got was they want to be involved. They do want to be more active in their health. However, they don't know how. In terms of when we talked to our stakeholders that were part of this partnership, we were also receiving messages of, we have a lot of resources, a lot of projects, a lot of programs, but no one seems to know that we exist or that we are available to them. And we want that participation. So that led to us really focusing on that disparity. There's a gap in communication within our community, and we felt that it was best for us to work on a training that allows these residents to be more engaged in these decision-making tables. We contracted with Environmental Financing West to help us with that training. Unlike asthma linkages, this project was planned for a 3-phase project. The first phase was empowering and building resident capacity. So focusing on a cohort of resident leaders who were interested in being learning more skills and being a little bit more active in our community regarding their health. Phase 2 was regarding empowering and building stakeholder capacity. So as we mentioned earlier, not only helping our community residents to be more involved, but understanding and helping our stakeholders to learn tools in how to engage these residents in a better way. And phase 3 was a joint summit, which was a one-day event that really brought these two cohorts together to understand how they can move things forward regarding health in Imperial County. And with that, I'll let Christina give you much more detail on these 3 phases.
So I'd like to start with you guys on phase 1, which, as Diego mentioned, was empowering and building resident capacity. For this actual phase of the process, we had a training period that took place over 3 months in May, June, and July of 2018. During that period, we were requiring participants who were part of this program to come on a monthly basis for 3 days of training in each of those months. That was an all-day Friday, Saturday, and Sunday commitment, 3 different times, which, as you guys know, is a lot of time. When we presented this idea of this whole training and this concept to the Local Health Authority Commission, you can imagine that there were definitely diverse perspectives on whether this was of value to the community or not. We had some people who could really understand and see why this was important and really understand the kind of root cause and working in the upstream world. But there are so many stakeholders who are still hesitant about that and said, you know, why would we fund this? Who really has interest? What impact is it actually going to make in the community? So we were actually thrilled to see that we had 46 applicants for this training program. We had an online application process where we required people to fill out a survey monkey with different information that talked about their leadership desires within the community, why they were motivated to be part of this program. And amongst that, we were pretty happy to end up selecting 27 participants that were qualified to continue and actually receive the training. Our evaluation process for selecting those 27 was all done by a panel of external reviewers. We had 4 different people as a part of that process. They were all outside the county. And by county, I mean literally outside of our geographic region, not just our county organization. So we had 4 reviewers, one of whom was from Rethink Health. So we were very happy to have CACHI's technical assistance in identifying Pedja, if any of you guys know him, as a qualified person to kind of help us move this work forward. So him and 3 others reviewed those applications, and then we extended those 27 selected participants an opportunity to be part of the training. Of those, 25 ended up accepting that invitation and participated throughout this process. I want to note that in addition to just the regular training where people were committing up to 12 and actually 13 days, because one of those trainings was a 4-day process at the very end, we also had 4 additional trainer spots. So of those 25, 4 of the individuals who were part of that cohort were actually given a $1,000 stipend to participate and receive additional training for a half day before each of these sessions. That was a part of our application process where they had to fill out additional questions on why they wanted to be a trainer, and kind of like where they had gone in our community as far as understanding and experience, and what they could really bring as a trainer to the capacity that we're looking to build. So this was a really novel concept, this idea that we needed to allow funding, and very much in line with kind of what we talked about with the Asthma Community Linkages project, funding people to be at the table at times when we understand that there really is that need in order to get them there for building that capacity. During this phase of the training, individuals learned about a broad variety of topics. We started with some personality type identification and group collaboration techniques, and then moved into more of message framing and understanding your target audience and identifying who that is, as well as speaking to them in a way that gets at their values. We talked about root cause analysis and how to test our assumptions for what we believe might be the reason for a problem. We also helped refine public speaking skills and work on message campaign development. Overall, we just heard wonderful things from the residents that participated. So we were very excited to launch into phase 2, which occurred after that initial resident leadership phase during the months of August, September, and October of 2018. This was also, the individual selected for this training was done through actually a variety of processes for this group. We had an online application, which we opened to all of the partners that are a part of our Community Health Improvement Partnership. As we had mentioned, our community formed its first ever health improvement plan, and we really realized that these efforts are trying to engage residents. So if we want to engage residents and stakeholders are saying that they're trying to engage residents, why not build capacity within those organizations that are a part of this process, that have poured their input into a plan to improve the health of our community? So through that process, we received 7 applications, and all 7 of those were accepted. Additionally, we opened up some seats to the Public Health Department, which, as you guys have heard throughout this presentation, really serves as a backbone for many collective efforts in our community. We ended up having 7 nominees that were selected through the Public Health Department for this training. And finally, we had a representative from the Local Health Authority Commission. As I mentioned, we really want to make sure that we're training stakeholders to be able to understand these kinds of techniques and tools that people are bringing to the table. We in our community, probably similar to many other communities, have some phrases thrown around like, well, it's always the way things have been done. And we're trying to make sure that our stakeholders understand that just because it's always done that way doesn't necessarily mean there isn't room for improvement. So this ability to bring phase 2 to the table was really empowering our stakeholders to understand that there are novel ways and there are exciting opportunities to try to gather new information and engage residents. They actually learned all of the same training tools that were taught to the resident leaders. So they had a very similar experience as the resident leaders, really building that ability to have a common language and a common set of tools to start working from. Additionally, we were excited about the opportunity in phase 2 to kind of refine things based on what we saw as needed as the process unfolded. As I mentioned, this is the first time our community has ever done this. So one of the things that we noted in phase 2 was that we needed a little bit more training on empowerment and disempowerment. And that conversation is something that really hasn't occurred a lot at tables that I've been in. So we decided that we really needed to bring that to the table because it's not just about verbal communication. It's about your nonverbal cues. It's about how you're interacting and choosing to empower somebody else at that table that gives them this opportunity to continue being a part of efforts that you're trying to engage them in. And it's really exciting to see that, you know, as we developed this as it was going, that was one of the really key pieces that those stakeholders latched onto and loved. So this training was definitely a success as well. Our stakeholders were excited about this opportunity to learn new things. It's not every day that you have a training in our community of this type of caliber, and so we were very excited to have that process occur. Finally, as Diego mentioned also, we had the joint summit where we brought everybody together. This was a one-day summit in November of this past year, And we had a good turnout from both of our stakeholder cohort and our resident leader cohort. They got together, and essentially it was supposed to be a networking event, allowing them all to meet each other, to kind of talk about problem solving together. They learned a new tool, which they all worked on. Additionally, we had some presenters that were kind of motivating our groups of leaders that had been trained to really get plugged in, to be a voice of change in the community, and to just be excited because we are so excited to have these new trained leaders in our community. Overall, this was a very successful process. And what we saw in the results of this were that people were just excited. They felt like the tools that they learned and the topics we covered were not just relevant for their work life or their volunteer life and engaging residents or engaging stakeholders, but they were relevant to their personal experience and skills. They felt like every day they were receiving things that they could take home and then translate into actual action, which is the true goal of this kind of training. We actually have a full report that is now available on our website, which details all of the results from this training. We both have quantitative data as well as qualitative from interviews and things like that. So I would encourage you guys to check that out. It's on www.localhealthauthority.org. And we're really excited about the results of this program. So as we wrap it up, I want to have you guys focus first on the right side of this slide. You'll see this beautiful graphic that has been evolving over time. We've used this for quite a while, and it's gone through many iterations, as have many of our other graphics, as we've learned and changed and grown. So within that yellow center circle, you see our CACHI portfolio of strategies. In our community, we tend to call them strategies as opposed to interventions, just because it resonates a little bit more with our community. And that portfolio of strategies spans all of the domains that we've talked about within that Accountable Communities framework. And we have our Asthma Community Linkages project, as Diego and Belen and Denise went over a little bit. We also have things like our health leadership and communications training, which are really working very upstream, empowering individuals who maybe not only have a passion for asthma, but any other health-related topic in the community. We realize that there's so much capacity to build, and that building it across a desire and passion areas where people can get engaged in whatever really interests them is super important because we have so much need and so much ability to start meeting need with anyone that's interested to be engaged in this process. We also have other strategies that are a part of that portfolio that focus on other areas of the domains. And we won't go into detail today on all of those things, but just know that they're in that portfolio. That whole portfolio sits within that blue circle of other local strategies that are occurring to reduce the burden of asthma. Within our community, we don't necessarily have leadership over everything that's occurring to improve asthma management. We want to fully acknowledge that there are other things out there. We'd like to align them and bring them into the fold with measures and different things like that. But there are other great efforts going on that are definitely contributing to asthma management in the community. All of these things are part of a larger group of collective efforts that our community is engaged in to really improve health and wellness overall within the community, which you see there in that gray bubble. And that whole effort right there is really what you're seeing on the outer ring, is that beautiful little graphic of having residents become engaged with our clinical partners, getting engaged with our businesses and our schools and all of these groups. Everybody has an opportunity to be part of something that can affect health. We all have different perspectives to bring, and we all have different audiences that we work with on a daily basis. And we truly are trying to empower all of these different sectors to be part of what we can do to improve our community. Our community as a whole has many goals and long-term visions, but one of the first that I think is really important to sum up this whole kind of conversation with is that we're redefining investment in our community. We're an area of high need. We have a ton of assets, as Denise mentioned. We're so proud of our community. But I think sometimes our conversation has been a lot around dollars and the amount of money that we really need to make change. But what we've realized in starting to do this work is that investments aren't just financial. The impact that we can make just by improving our partnerships, by activating committees, or even by being stewards of these concepts and taking them and growing them in other places, is just phenomenal. So that real redefinement and of how we think about investment and move those investments in our community is a very important concept. Additionally, we're focusing on sustaining infrastructure changes. We want to do things that are going to last for a long period of time, not just continue the cycle of funding things through a grant and then having them end after a period of 3 or 5 years when things are over. We're working on improving partnerships. We're small communities, so everyone knows everybody, and we've got the history of all those things. And as I mentioned, we've just realized that so much can be done if we talk through these things and improve the ways that we're working together, and even just make time to have that conversation. Finally, we're creating information pathways. That's super important and includes things like data sharing. It allows us to be able to communicate more effectively about the changes that we're making, but to also share information that's relevant to the whole entire person and how we care for that person. It allows us to address social determinants of health and really allows us to tell a picture of what we're doing within our community. So we're excited about these collective efforts, and we thank you guys so much for allowing us to talk a little bit about them today. Thank you.
Great. Thanks so much to all of you. This was great. Most appreciated.
Thanks, Sue. We appreciate it.